Welcome to the 8 o'clock session. Really excited to be part of this program and to be participating in the 12th hour after a lot of really excellent talks. I want to start by introducing our panel members, and I have some slides that we're going to share separately so that you can see them and follow along. The topic of this hour is the importance of representation in orthopedic surgery residency programs. So next slide. I'm Rachel Shakked. I'm an associate professor of orthopedic surgery at Jefferson University here in Philadelphia. I'm the director of the foot and ankle rotation for Temple University Orthopedics Department, and I'm also a fellowship attending at the Rothman Orthopedic Foot and Ankle Fellowship. I completed my training at NYU Orthopedics in New York City and my foot and ankle fellowship in Hospital for Special Surgery. Can go to the next slide. Introducing Dr. Wen Chao. She joins us from the University of Pennsylvania in Philadelphia. She's been faculty there for over almost 25 years. She completed her orthopedic residency at Jefferson University and fellowship at Hospital for Special Surgery as well. And in addition to volunteering as a reviewer for Foot and Ankle International and Foot and Ankle Orthopedics, Dr. Chao serves on the Public Education Committee for the AOFAS. And something that I find so interesting is that she has been the orthopedic foot and ankle consultant for the Philadelphia Ballet since 2001. Slide. Dr. Natalie Danna is joining us from University of Maryland, where she is an assistant professor and the residency program director. She serves on several important committees, including the Residency Review Committee, the Graduate Medical Education Committee at the University of Maryland, and the AOFAS Young Physicians Committee. Dr. Danna trained with me at NYU Orthopedics and then completed her foot and ankle fellowship at Baylor University Medical Center in Dallas, Texas. And finally, Dr. Monica DiFiori is a current PGY3 orthopedic resident at Temple University Hospital in Philadelphia. And as a resident, she's completed research presentations at national and regional conferences, assisted with the care of Temple University varsity athletes on the sidelines, and has been an active member of the Temple University of the Ruth Jackson Orthopedic Society chapter at Temple. She was an undergraduate at Trinity College, where she was the starting goalkeeper for the women's soccer team, and went on to complete her medical degree at Temple University in Philadelphia. And I'm really excited to have her here to give us a perspective from a current resident. Slide. So the importance of representation in orthopedic residency program. We were tasked with this project, and I started out by asking myself, what is the actual definition of representation? What should we discuss in this hour? So in my mind, there's two main definitions. One is the portrayal of someone in a particular way, and we'll talk about this in the context of representation of different groups related to diversity. But representation also is the action of speaking on behalf of someone, so giving residents a voice. And this is a separate definition, but related in that underrepresented groups in residency often have less of a platform. How do we define diversity? It's not only residency, it's not only race and ethnicity. The context matters. So women make up half of the population. 50% of med students are women. But in orthopedics, women are a minority and are underrepresented, and were therefore considered diverse. So in my residency program pictured here, I was considered diverse. There's lots of different types of diversity of background, gender identity, socioeconomic status, religion, age, etc. So my first question I'd like to pose to my panel here today is, how do you think the definition of diversity has evolved over the course of your careers? Feel free to chime in.
I'll start. I recall being a medical student, just becoming interested in orthopedic surgery. And the big topic, the big deal at that point for me and for my advisors was just the fact that I was a woman. I mean, that was just like, well, I don't know, that's really going to be the barrier here. And that's just, the climate of orthopedic surgery, at that time was that it really was just the boys club, and it was a really big deal. And that was the hurdle to overcome. And I think that at this point in time, while I'm not currently, a medical student just getting interested in orthopedics and having that, first foot in the door, it has seemed to me in advising medical students now that that isn't sort of that first barrier that they're hitting, that they can look, at least in our residency program, and see several women. They can look at our faculty and see several women, and that's kind of not the issue, and that the diversity question has sort of become deeper and more nuanced now, because we've sort of gotten past that first hurdle of, well, it's just, this percentage of men, which is overwhelming, in this field, versus this percentage of women. And we're kind of past that. And now it's, well, what is your background? Where are you coming from? What else sets you apart, makes you different, special, and might make you feel isolated. So there's just a lot more to it. I think as we make progress, it sort of opens a new can of worms.
Yes. So the diversity of types of diversity, really.
Yeah.
At this point.
Yes, and I agree. Sorry, I have laryngitis, but I feel fine. Because I did my orthopedic training in the early 90s, and my graduating class looks very similar to Rachel's fellow residents. But in the 2020s now, the definition of diversity has broadened. Right? Diversity, it's more than just male or female. It's gender, it's race, it's religious and political affiliation, it's your sexual preference. So the term diversity has become much, much broader than when I went through training in the early 90s.
Yeah. So I want to take this moment to really talk about, and we can go to the next slide here. When I started putting my thoughts together for this, I was wondering, why is representation so important in orthopedic surgery residency? If we're here selecting the best, the brightest medical students to train in our programs to be the next generation of orthopedic surgeons, why does it matter what holiday they celebrate, the color of their skin, their gender identity? Why is all of that relevant? And in doing a lot of reading about this, I found that this is actually called the merit versus diversity myth. And many of you may have already heard about this, but I had not. So I did some more exploration. And really, it states that diversity does not mean lowering standards. The goal of diversity initiatives is to broaden the qualified applicant pool by eliminating biases in the selection process. And although talent is evenly distributed, opportunity historically has not been. So representation is important. You can go to the next slide, because it leads to excellence. It benefits society. It financially benefits hospital system, and it advances our field. And over the course of the next 45 minutes or so, I'm going to prove that to you. Next slide. So it is a proven fact. You can play the video here. It's a proven fact that diverse teams perform better. This is well studied in the business world. Companies with more than 30% women are more likely to financially outperform those with less than 30%. Companies with higher ethnic diversity are 27% more likely to financially outperform less diverse companies. Will it play? It's important to see the end. Can you go back and play the video? See if it'll play. Companies with diverse leadership have 19% higher innovation revenue. Companies with higher diversity in leadership roles are 70% more likely to capture a new market. This video shows how two teams develop a solution to the same problem. So after this video finishes, I'm going to open it up to my panel again. And I want to know, have you led or participated in teams that benefited from diversity? And what did that look like? Do you notice different perspectives or ideas emerge in more diverse peer groups? You can see here how these two groups of people develop different solutions to the same problems. Thanks. Next slide now. So what do you guys think? Have you ever seen this happen where a diverse group led to a benefit?
Yeah, I think that in a general sense, certainly the efficiency of coming at the same problem from different directions, can be seen with big problems and with very small ones even. It's just a fresh perspective is certainly, always helpful in terms of creativity, efficiency, and I would suspect satisfaction of the participants too. Everyone kind of likes to be exposed to new ways of doing things or just something different, someone different.
Something that always comes to mind with this question for me is that in residency, when we had to do hip dislocation reductions, and in general, I felt like maybe I didn't have the same power that some of the guys did, although I was definitely stronger than other of the guys. But there were different techniques that I feel like a lot of the women residents discussed to be able to reduce a hip or reduce a shoulder using finesse, rather than brute strength. And I felt like that, and it wasn't just something that the female residents or the residents who didn't have enough strength or as strong as some of the guys were able to use. It was something that anyone could use, and it was probably, like you said, better for the patients, not as aggressive, and still accomplishing the same ends, just with a little bit more elegance. I don't know if you ever saw any specific techniques that helped you in residency, like in the emergency room for reductions.
Yeah, Dr. Shakked, I think that's a really great point. Like as a more junior resident, you're learning how to do these reductions from senior residents. And I was very lucky that there was a chief resident who was similar in stature. We're both like kind of petite women. Neither one of us is taller than 5'5". And so learning how to do a hip reduction from one of my chiefs who is a 6'5" guy, played football in college, like his technique was much different than hers. And so just that diversity and learning like how to do different things. But I think like what you're alluding to is that if something isn't working with a reduction, there's something wrong with your technique. It's not just about like Hulk smashing things together and just being like strong and pressing stuff together and hoping it sticks. It's about like understanding the technique and understanding like the mechanical forces that are at play. And if you understand those, then you'll be able to get it. And I think watching the female residents that came before me at Temple learn that and understand that and then teach me was a huge benefit of being in a program where there's a lot of women.
Yeah, so I love that, like a specific example of how diversity has actually benefited us in our training. Okay, so let's move on to the next slide. So not only does diverse representation lead to excellence, but it does benefit society. It reduces healthcare disparities. It builds a healthcare workforce reflective of society. Underrepresented physicians are known to be more likely to care for patients in underserved areas, improving access to care. Next slide. What about the institutional benefits of diversity? Does diversity in the residency program actually benefit the institution itself? Is there any effect on the hospital's metrics and profitability? So diversity in healthcare teams improves patient outcomes and satisfaction. When a patient sees a physician with a similar background, they feel more comfortable and understood, which then leads to better compliance and can ultimately benefit the hospital's bottom line. For example, Black male patients seen by Black physicians are more likely to agree to preventative services, which is estimated to then reduce the Black-white cardiovascular mortality gap by 19%. Diverse healthcare teams are associated with higher patient satisfaction, better adherence to treatment, and improved care quality. And this is one of my personal favorite studies, and I think you would agree. This is published in JAMA in 2021, found that patients treated by female surgeons have lower 30-day mortality, readmissions, and complications compared to male surgeons. And these are all things that hospital systems are measuring and tracking to determine their success and their financial profitability. So healthcare organizations are seen as more progressive and responsive to community needs when diverse. Next slide. Orthopedic training programs also benefit from diversity. A diverse program signals a modern, forward-thinking, and inclusive culture. It attracts top candidates, faculty, philanthropic support. Diversity in orthopedic residency also does not sacrifice quality. Board scores and productivity are no different between male and female ortho residents. And we know that diversity strengthens program culture, learning environments, and physician well-being. It reduces employee attrition and increases employee motivation. So another question for you guys, you ladies, rather, sorry. This panel, have you witnessed any examples of how hospitals or training programs have benefited from building more diverse teams?
Yes, absolutely. I am at Penn Orthopedics, and we have 8 residents a year, and so that's a lot of residents. And we have residents from all over the country, all over the world. So just, personally with their background, it just brings so much diversity to our residency program because, one of the residents from Wisconsin, and when I first met him as an intern, I said, you know what? I've never met anybody from Wisconsin. And we have a resident from Ethiopia, a resident from Nigeria. So, just by their background difference, it makes our program and the hospital and the patient care so much better just because they're diverse background.
Yeah, and I think that that extends even to a diversity in training programs. I think probably I've seen it a couple of academic institutions where I've been, but people tend to gravitate to where they trained. So the faculty becomes, trained at that institution, and then everyone kind of does things the way they've always been done, unless there's a really great motivator for change. Whereas when someone comes in from the outside and says, hey, that works, but also this is the way I saw things done and it was great too, why don't we try this? And I think that there is also just a freshness that can kind of come from outside perspectives, whether background as far as where a person grew up or even just a training background.
Do you think, Monica, do you think that helped you in deciding where you wanted to train also by seeing a more diverse team, depending between all the different programs that you may have interviewed at?
Oh, absolutely. I was a medical student at Temple, so being able to see some of the female residents at Temple kind of progress through their training, watch how they interacted with their co-residents, with the attendings, the support staff, was a very formative experience. And that was all I knew before I started going on my away rotations and exploring other programs and interviews. And so seeing how the female residents at Temple worked and then comparing what I was seeing on my away rotations and during the interview process, I realized that not to create Temple as this a fantastic example, because they are a very good one, and I'm sure there's others out there. So my experience is very biased, but I realized that there were all these little things that I took for granted that were at Temple that didn't necessarily translate at other programs. And so coming back to make my rank list, I realized that I wanted to be in a place where I knew that I would feel comfortable and supported. Didn't always mean that there were a lot of women residents or a lot of women faculty, but I just watched the way that people interacted with each other and noticing that those little things are going to really dictate how I would do over the next 5 years. So certainly that made a huge difference in my path to residency.
A small point that Monica brings up there, you said your experience is biased. It is, and everyone's experience is biased, and we don't even know sometimes, where our blind spots are. And I think the way out of that bias is to bring in other people who are biased in different ways and really listen to their perspective and try to, just integrate what they've seen. And I think that's the best way to kind of broaden our perspectives.
I love that, actually, and that is a perfect segue to my next slide, which is talking about bias and implicit bias. Like our interview process that we use to hire new residents to interview medical students has a lot of built-in bias. Like we prefer candidates with familiarity or with connections, where I constantly find that after interviewing a medical student, maybe someone says like, oh, well, they don't seem like a good fit. So, and what does that mean? So we're underestimating resilience or leadership potential in non-traditional candidates. And implicit bias is partly due to societal pressure that shapes our beliefs at a shockingly early age, often without us even realizing it. Before someone even applies to residency or med school, there's a lifetime of subtle messages that shape how they see themselves and how the world sees them. So the next video clip that I'm going to share illustrates how seemingly harmless stereotypes begin to take root and later influence the way we see ourselves and others in professional settings like our own. So let's play the next video.
Hi. Okay, so I'm going to just give you some actions to do. I just do the first thing that comes to mind. Show me what it looks like to run like a girl.
My hair.
Show me what it looks like to fight like a girl. Now throw like a girl.
Aw. My name is Dakota, and I'm 10 years old.
Show me what it looks like to run like a girl. Throw like a girl. Fight like a girl. What does it mean to you when I say run like a girl?
It means run fast as you can.
So do you think you just insulted your sister?
No. I mean, yeah, insulted girls, but not my sister.
Is like a girl a good thing?
Actually, I don't know if it's a bad thing or a good thing. It sounds like a bad thing. It sounds like you're trying to humiliate someone.
We can stop it there.
So,
Hi.
So at some point between childhood and adolescence, something shifts. And what starts out as a neutral or even an empowering description, run like a girl, fight like a girl, becomes an insult. And if that can happen so easily, we have to ask ourselves, where else is it happening? Is implicit bias like this affecting our hiring processes? So I would love to hear from the panel what stood out to you in this video. Did it surprise you? Did it feel familiar? And how do you think these early subtle messages about gender and capability manifest in our own fields?
Yeah, I thought that was a really good pick that you made for this session in particular. What stood out to me most, I guess, was the average age of the first group versus the young girls, the second group, who are obviously much younger. And so, the obvious question then is, where does that switch happen, and can we intervene, before it does? Because it certainly it is powerful and pervasive. As a mother of both young boys and girls, it's been interesting to me since they were born. Just sort of in terms of how other people approach them. Grandparents will be over and they'll say to my boys, "Look outside, there's a garbage truck," and they've never said that to my daughter, and so I try to point out the garbage truck because she could be similarly excited about the large truck outside. But it's and none of the people who are doing that, including myself, and I'm sure I'm doing it in ways I'm not even aware of, are intending to send a message to them. But you look at the toys that are for boys versus girls, which are creative toys and building toys, and which are sort of collaborative caretaking toys, et cetera, et cetera. But it's sort of very powerful to see it side by side in a video like that.
You have your own case control study in your house.
I can share my personal experience. I am a girl. I'm the oldest, and I have two younger brothers. So my one brother said, "When you run like a girl," I said, "I am a girl." As long as I do my best in running, that's all that matters. So I learned at a very young age that but of course I'm the oldest. I can beat up my two younger brothers. And the other thing is because I am the only girl in my family and only daughter, I just love like tools. And my dad was putting up paneling in the basement, and I said, Dad, I could help. And my dad would say to me, you know what? Go get your brothers. I said, no, Dad, I'm really interested in this. This is fun. So like him and I, we put up the paneling. This is in the 70s, of course.
Sounds like it.
So yes, as a girl, as long as, you just try your best, that's all we can do.
So I think to answer the last question, Dr. Shakked, how does this like translate into orthopedics? I think the question of are you capable comes up as the female resident, as the female surgeon. And I don't think that doesn't come up when the resident or the fellow or the attending is male. And it comes from everybody. It comes from like the administration staff, the support staff in the ORs, on the floors. It can come from your colleagues, like your co-residents, fellows, your fellow faculty attending, but it also comes from the patients. So it really like permeates through everything.
Yeah, it's hard to escape. I mean, I have to be honest, when I watched this video, it honestly, until I watched this video, it did not occur to me that saying run like a girl was an insult. Like it was so ingrained in me from growing up and hearing that like, yeah, okay, that's like the joke, run like a girl, but it's insulting. And it made me think that maybe there is some good to social media, right? Like that's how this video came across my desk, is that it became popularized. And it like kind of woke me up and made me realize that like, no, that's not okay actually. And I think there's a lot of things like that are in like a really well done way are showing us some implicit biases that we have that like I, as a underrepresented female in this field, didn't even realize I had. Okay, and then let's go to the next slide. So do you have any ideas about what institutions can do to proactively challenge these biases in recruitment and also in daily program culture? Like, is there anything that we can actually do to improve this?
I think there is. I think that it's harder to think, I guess, at an institutional scale. But people make up the institutions. So on a more individual scale, I mean, having genuine curiosity about people who are different. I think if the curiosity is genuine and not sort of implying that they're different and not as good. I think in terms of even just in an interview process, attracting those diverse candidates and having them, have a feel for a place and feel like, they would be a valued member of the team. I think that also the change in incorporating diversity and representation shouldn't be a grassroots change. I do think it should be top down, when the leadership of an institution acknowledges the power of representation and diversity, it validates that and the people who are involved in a way that just, co-residents validating, a diverse member of their group, doesn't. When the person feels valued and seen by leadership, I think it sends a different message that is more inclusive and more likely to propel the change, as opposed to just, the leadership ignored that I was different, but my co-residents liked me. That's a different feeling than someone who feels, really valued and seen, and like they can make contributions that highlight their diversity without needing to hide their diversity. And I think that is something that even having panels like this can put out there. I mean, because again, when I started training and it was like, oh well, you're a woman, how will you do this? I sort of felt like I wanted to just downplay that, and just act like everyone else and not mention it, and it would all be great. But now I think that if we're valuing diversity, people can act in a way, say things in a way, bring ideas to the table that highlight that they're not the same as everyone else, because that is an asset.
Yeah, 100%.
The first thing that comes to mind is inclusion, because if you include everyone, that covers diversity, and I believe that most large institutions do that, right? Because if you include everyone, and just because of inclusion, that automatically brings in diversity, and just having that as the basic concept to a large institution, and I think that would be super helpful.
Mm.
I believe most large institutions do that already.
Yeah. So inclusion, I think, also ties into representation, really, which is what we're tasked with talking about. So the issue is really that, like, if these biases that we have go unchecked, it can affect the way we hire, mentor, promote, listen to our colleagues. So inclusion is important, and I totally agree that it really needs to come from the top down. So I thought we would switch gears at this point. So the word representation is not only about demographics, it's about having a seat at the table. So it's not enough just to recruit a diverse residency class, but those residents also need representation in policy development. Otherwise, you risk tokenism without impact. So we'll talk a little bit now about the other half of representation, which is resident empowerment and giving residents a voice. So we can go to the next slide. Studies show that underrepresented minorities and women residents face higher rates of discrimination, microaggressions, and burnout. And I think we can all attest to that. I mean, I felt like as a resident, I had to work twice as hard to be accepted, to prove myself. And that happened at every level. Every time I went to a new location, a new rotation, when I finished residency, went to fellowship, you have to prove yourself over and over again. And it's tiring. So the other interesting thing is that underrepresented minority and women residents feel that they're less likely to safely voice their concerns without retaliation. Next slide. So over 20,000 residents right now are unionized, and this is a very present topic, especially here in Philadelphia. A lot has changed recently. These movements, interestingly, have often been led by women and underrepresented minority residents. Next slide. So resident empowerment, the unionization movement isn't just about pay. It's about advocating for fair treatment, for parental leave, safe working conditions, and programs that have a formal channel for residency advocacy tend to see better outcomes in wellness, retention, and program satisfaction. So my next discussion point with our panel here is, how can residency programs ensure that residents have a voice? And then how can residency programs balance the needs of the resident with the pressure of the institutional profitability and efficiency? Thoughts?
I'd like to speak to the role, in particular, the question of residency programs ensuring the residents have a voice. In my institution, and I take no credit for this because it was here before I assumed the program director role, but we have a monthly session with the residents called Roundtable. We don't have a roundtable big enough, so it is rectangular, but that's okay. And it is with the program director, myself, and the chair of our department, and all the residents. And it's an opportunity for them to bring any of their concerns. And so that's mostly for our program. It's not at the institutional level, although they certainly can bring concerns that they're having in other departments or with other services, et cetera. And it's, even though we call it roundtable, it obviously can still be intimidating to speak up in a large setting like that and with program leadership. So we also maintain an email address that they all have the username and password to, where anyone can just pen an email and plop it in there. And they've got one sort of designated spokesperson that will bring any concerns to that. So it's sort of small, but we want to make sure that the residents and any level of resident is being heard. Certainly when I was a resident, and Dr. Shakked can attest to this, I mean, we were very hierarchical, and, the interns were not supposed to be heard about anything, and it was up to the senior residents, the chiefs, et cetera. But, we are trying to make sure that from the start, maybe, in a way to address resident satisfaction, reduce attrition, that sort of thing, that we're hearing all levels of resident.
Do you think that, obviously residency is very challenging and you need to put in a lot of hours to learn our trade and to be good surgeons and good doctors and know enough to complete residency and go out in the world. And I always felt that asking about call schedules or work hours or anything made it look like I wasn't interested or like I didn't want to work hard. I felt like if I voiced any concern, any question about that, it would make me look lazy. It even extended to when I finished training and was looking for jobs. I didn't want to ask about what was involved in the call burden because I didn't want anyone to assume that I didn't want to work hard. So do you think that the residents are feeling comfortable voicing those concerns now, or do you think that the anonymous comment section essentially has helped with that?
I personally think the residents feel quite comfortable voicing those concerns, and that's good. It's tough whenever there is a cultural shift, right? I think quick period of time, we went from, there were work hours, but you just recorded the proper ones and did your job to, we're accurately recording, including a little cushion for walking to your car, and so it's tough to be leadership on the complaint end of that, and you want to just say, come on, like when I was a resident, right? But I mean, I can also remember being a resident and what we had to hear. Well, when we were residents, there weren't even work hours,
Yeah.
So it's like there's always a generational shift, and it happens quicker than an age generational shift, which maybe is hard to swallow. But I do think that for the better, people are comfortable voicing those concerns, and there's back to my own bias. I guess I won't know if somebody isn't comfortable because they're not voicing those concerns. But for the number of concerns I hear, I think they're comfortable.
And I want to ask specifically for Monica, like from the resident perspective, do you think that that by being able to voice concerns and hopefully putting the residency programs in a better direction, taking care of their residents, that it will enhance your learning actually, because you maybe have the hours are a little bit better, your brain works better. Like, do you think that actually that's beneficial? Because I think from the perspective of the institution, they just want residents to work all the time, 24/7. And therefore, by being in the hospital all the time, they're learning everything. But in reality, does that actually happen?
Yeah, that's a great question. And I think, yes, there's work hours for good reasons and everything, but like you were saying, just being in the hospital doesn't always equate to learning all the time. I think, especially when you're a junior resident, carrying the pager, you're helping out with like all the floor things. The extra time that you're spending in the hospital is usually not related to any orthopedic learning. You're transporting the patient to get their imaging, you're transporting them down to the OR, you're organizing their discharge, and like all of those things are good things to know how to do, but at a certain point in time, that's not really furthering you as an orthopedic surgeon. And so I think in Temple's execution of like the 80-hour work week rule and everything, it's really cut down on those tasks that residents were largely responsible for that aren't actually helping you become a better orthopedic surgeon. I think everybody knows how to push a patient in their hospital bed from the 8th floor down to the OR, and there are other people whose jobs those are, but largely it falls on the residents to get it done. And so cutting out those types of things, I think, is really beneficial. When I was interviewing, one of the program directors said something that's really stuck with me, and he said that the department should exist for the residents. The residents don't exist to maintain the department. And I never really thought of it like that. And then when he said that, I realized like the hospital systems depend on the residents to fill in all of these gaps so frequently. And that kind of contributes to that mentality of like burnout and attrition, because you didn't decide to become an orthopedic surgeon to push patients to the x-ray room and back. You did orthopedic surgery because you want to do the surgery. So I think always understanding that every decision that you make in a leadership position for the program or for the department, if you keep that in the back of your head, like, is this decision going to help the residency and help create good surgeons, or is this relying on the residents to fill in a gap that we can't fill? Will change the culture and likely the efficiency of the department as well.
Yeah, that's a really great perspective, actually. And how about at your program? What kind of like channels do residents have to give them a voice that maybe can apply to other programs around the world?
We have a similar roundtable concept, like Natalie mentioned, except our residency director meets with them once a week.
Oh, wow.
I mean, it's with them virtual, so it's a lot easier, right? If you're like, at a rotation off site, you can still participate.
Mhm.
So I think that's really helpful. And again, our program's pretty big, and everybody has a voice from a PGY1 to a PGY5. So I think that's really important. That's one thing. And the second thing is, we want to make the residents happy, and we want to create a family environment. So this year we instituted the first Friday social. So as an example, and it's it's like residents, attendings, staff, they can bring family. So I went to the one was bowling.
That's fun.
Yeah, it was so much fun, right? And of course, like you're waiting to bowl, waiting for your turn, and you get to talk to the residents. Sometimes they bring their family, so it's super helpful. And I really think that creates almost like a family environment in a like long journey, as a resident, because we do care about them.
Yeah, I love that. That's I think that's important. And do you feel like how do we sort of take away that fear of retaliation in a program? Because I know I still have that feeling from when I was a resident that I was like afraid to speak out, and you just have to put your head down and work and get through it.
Oh yes, because again, I trained in the 90s, right? And that was well before 80-hour a week.
Yeah.
I mean, you're there just to get the work done. Taking the patient to X-ray just to get it done.
Right.
But now I think as an attending, like I'll get in trouble if I retaliate. It's becoming that kind of environment now. So, right, like everything is you can't say anything back to anybody anymore. And
yeah,
I mean, I hate to say it, but
the collective, because I guess there's been a shift, and everyone's more comfortable speaking out. It's been okay, I guess, or it's been going in the right direction in terms of residency voice, residents having a voice.
Correct. And if you just we have an open door policy. So if a resident has a complaint against me, I tell the resident, like just say it to me and we'll work this out. And
I can't imagine anyone would complain against you.
Oh, thank you, Rachel. I know residents are like, oh no, she doesn't. I mean, I don't yell at all. So, but just to have an open door policy, I think that's really helpful, just to let the residents know, so that they feel comfortable in coming to me. I said, even if you have a family problem, just come to me. I'm a mom. I totally understand. I went through this myself, back in the 90s. So, again, I think all of the attendings have an open door policy to the residents.
That's great. I mean, do you think that academic medicine sort of attracts physicians who are more interested in residency advocacy and making sure that residents get good training while still having a good environment?
Oh, absolutely. Because, it is such a headache if we lose a resident for any reason. So it's, the goal is they're here to learn everything they need to learn about orthopedic surgery, be a family person, be a good person. And if there's any complaints, just if you don't complain, we won't know about it. So just voice your concerns and then we'll work on that.
Yeah.
I think there's something that's helpful to also in terms of inviting feedback or complaint, depending on how we look at it from the residents, is just also acknowledging like what their situation is. Like work hour restrictions or not, residency is still really, really hard. Like there's still a lot to do, and so, the nitty gritty over the exact number of hours, et cetera, and people may be feeling uncomfortable about speaking up when, they think things are unfair on different rotations, whatever, acknowledging that that we remember what that training was and that it is really difficult and that we have some sympathy for that, but that if you want to become an orthopedic surgeon, this is what you have to go through, and that, we're kind of here as a sounding board, if nothing else. But, I recall from training, one like single faculty member who had trained several decades before, who said, yeah, we didn't have work hour restrictions when I trained, but you know what? We didn't have nearly as much stuff to learn either, because we didn't know that much. All you had to do was show up. And yeah, you didn't go home for a while, but you didn't have to read anything or write any papers, because that wasn't a thing either, and so some acknowledgement that that it's still not easy, that nothing is easy. It's just different than when we trained, I think can also help bridge that gap between not having sort of an us versus them mentality.
That's a really good point, actually. I actually remember as a medical student when one of the hospitals we worked in switched over from paper charts. We were still using paper charts in one of the hospitals to electronic medical records, and our notes were a joke. I mean, it was it was entirely abbreviation.
Yeah.
I don't think there was a single full word in the note. So
and you could just scribble it. It took 5 seconds, because forget you didn't have to copy forward. No one had to read your writing. It was just I remember the same thing as a medical student. We were writing paper notes every day.
Yeah. And it was so much faster. And so it's such a good point that yes, we have work hour restrictions, but the residents are not working any less right now. It's just the work has changed, really.
Right.
And the expectations have changed.
Right.
Yeah, that's a really good point. Okay, well, let's move on to our next. We're getting close to the end here. So we can go to the next. So really what I wanted to get out of all of this is to talk about how implicit bias can really be affecting how our field is not as diverse as it probably should be. And that residents themselves are working harder to have a voice. So what I would love to hear from you is what is a specific thing that we could change? If you could change one thing tomorrow in how residency programs approach representation, what would it be? It's a big question. Any ideas? Or have you seen anything specific change because you've had a voice? Because now it does sound like residents do have more of a voice. So is there anything specific that has come out of that for the better, that has improved your life or improved the life of your residents?
Yes. Again, I've been around for a very long time. And I remember when I was a resident, one of my senior attendings, always the first thing he would say to me is, "Wen, how are you doing?" And that just, that ingrained in my mind, say, wow, Dr. Kotler, he didn't care about, how my patients are doing. It's like, how am I doing as a resident, after being up all night? So I just think that if each attending, in a residency program, just ask the resident, the first thing that you see the resident, how are you doing? And how is your family, if they have a family? Or, and I really think that makes a really a big impact. So if I could just tell every one of my colleagues in my program and just say, look, instead of confronting the resident about something that went wrong, you got to care about the resident first. So just take the time out and just say, how are you doing? and then go on to the next thing.
That's great. That's like a very simple take-home message that can probably make a big impact. I like that.
That is great advice. That is. I think, so one sort of concrete thing, I think really is, well, it doesn't sound concrete, but celebrating the diversity. I mean, really just trying to show that we appreciate, where our residents are, and I don't just mean diversity in background, as we were talking about in the first half of the session, but also just diversity in level of training, that the intern is as valued as the chief, and just kind of really highlighting that for the residents so that they sort of feel seen. I think is one way to make everyone feel valued, and people who feel valued, have higher satisfaction, and this may sound self-serving, but they also work harder, right? Like a valued member of the team does better work, but also is happy to be there and helps pull other people up with them, et cetera, et cetera. And so, I think in particular, recognizing the different levels of residents as well, and how they build the bigger whole is important.
Yeah, I mean, I think that having people who are part of your team work harder, it is an important piece of it. I mean, unfortunately, medicine is a business, and hospital systems need to make money, and therefore they want us as the surgeons and the residents to work. So in proving our point that diversity is beneficial, I mean, it's generally good for the world and good for us as a diverse group in orthopedic surgery, but we also have to show how it benefits the system and the bottom line of the hospital system, which according to all of the research that's done in the business world, it does. So supporting our groups is important. How about you, Monica? Any ideas of actionable change?
Yeah, I think I have one kind of unrealistic goal, which would be to remove tokenism from the interview process in its entirety. Very unrealistic. I don't think that'll ever happen. But the one realistic change that I think is super easy and can be done every day is the way that our attendings introduce residents, fellows, even their fellow colleagues. I think there's this unconscious bias to introduce male residents, male surgeons as doctor and then insert last name, and then to refer to female residents, fellows, attendings just by their first name.
I'm guilty of it. Well, this is casual, right? But totally.
In the hospital setting in front of patients, I think it happens a lot, and then it creates a confusion for the patient, because if you're referring to their surgeon as Dr. Gallos, or one of our male attendings, but then one of our other trauma attendings, if one of our someone refers to her in front of a patient as her first name as Megan, now the patient is well, is she my surgeon, or is she my nurse? Is she the PA? That kind of questioning happens a lot. And so one of the things that's made a difference to me is I've noticed that some of the attendings, when we go on rounds, they always introduce me as Dr. DiFiori. They never refer to me as Monica in front of the patient. And then in the instances in which someone refers to me by my first name in front of the patient, then they're like, oh, well, this is just my nurse. When am I going to see the real doctor? And I'm I'm on call. I'm the only orthopedic surgery in the hospital. I'm sorry, it's just me. That's all you get. So I think that.
Or better yet, you're lucky you got me. Change the narrative entirely.
I love that.
I like that. So I think that little change in front of patients is really a simple thing to do, but makes a big impact.
Yeah, that makes a lot of sense. Do you think is there a good way to correct someone? Because that's one of those implicit biases, right? It's done unconsciously and usually not maliciously. It's just built in because of how our society is. So do you think that there's a good way to speak out in a respectful way, I guess, that says actually, would you mind referring to me as doctor? Because of that reason, it's a very valuable reason and valid.
Yeah, I think in the instances where there's been a confusion of my role on the team, I've been very lucky at Temple where our attendings correct the patient like immediately. Maybe they don't realize that because because they said like, oh, and Monica was telling me about this on rounds. They don't realize that that's where the confusion stems from. In those instances, I find like someone said to me once, like, praise in public, correct in private. And so I never say anything in front of the patient. But maybe after rounds, I'll say like, hey, Dr. Solar is like, this was a really uncomfortable situation for me when the patient wasn't sure if I was a resident or if I was their nurse. Like, next time we go on rounds, can you say like Dr. DiFiori instead in front of the patient? And then they immediately are like, so apologetic, like I didn't even realize. Like, like you said, it's never out of a malicious intent. It's just an unconscious habit that they have.
Right.
But most people are willing to correct once it's pointed out to them.
Uh-huh.
And only because it's easier to see solutions for other people than for yourself. What I'm thinking as you're talking, Monica, is Dr. DiFiori is, that if the attending is referring to you as Monica in front of the patient, and then if it's your turn to sort of jump in and sit into the patient, like, oh yes, we spoke about this yesterday, Dr. DiFiori, and just kind of reestablishing for the patient that you're the doctor, which might even be sort of a subtler nudge to the attending if you don't feel comfortable bringing it up in private. But of course, if you do, I mean, that's even better to be direct about it.
Yeah, that's a great suggestion. I love that.
Yeah. All right, well, we've only got 2 minutes left, so I'm going to finish out our presentation. We can go to the next slide. So we talked about some actionable strategies for change, like a holistic review and recruitment, intentional sponsorship, culture audits, bias training, and a visible leadership pathway for underrepresented groups. You can go to the last slide. So diversity is a strategic advantage for training programs. You can go back one. Mm-hmm. And for our patients, every study we have on diverse teams in business, healthcare, education shows improved decision-making, innovation, and outcomes. It's not just a box to check. It's a strategy for excellence, equity, and progress. So it really is important that this is an ongoing conversation. Our work here is not done. And I just want to thank Dr. Selene Parekh for organizing such an incredible global event. And a really big thank you to my esteemed panelists for joining me in this complicated and important conversation. Thank you so much.
And a big thank you to Dr. Shakked for all her hard work on putting together such a great presentation.
Yes, definitely.
Thanks, guys. Have a great rest of your day.
Yeah, thanks so much, Dr. Shakked.